Hey everybody, welcome to Psychopharmacology, week 3, week 4, whatever it is now. So we're going to review bipolar disorder. All right, I know it's a big topic, and we discussed unipolar depression last week. Was there anything that wasn't clear that we can start out with about treatments that I didn't cover last week? No?
Just
Yeah.
with some of the like adjunct medications like for treatment resistant depression, like cariprazine or aripiprazole, any of those. So they
Okay.
discuss like main receptors that are hit, right?
Hmm.
Like it's like D2 antagonist, 5-HT1A partial
Hmm.
agonist. But then Stahl goes on to discuss like secondary receptors that are hit, and with some of these meds, trazodone, for instance, there's like 15 receptors. Should we focus on just the receptors that have antidepressant properties, or should we know every single receptor that this drug hits for testing purposes, at least?
Yeah. So I think from this point early in your career, just know the receptors are implicated for depression. So can anyone give me some receptors that, what about you, Evan? Let's open up the floor. You mentioned some receptor sites there, right? All the ones that you said were correct, but there was one that actually can worsen depression. You said it first. D2 antagonism, right? So D2 antagonism, we're going to talk about that when we get to schizophrenia. But, if you're talking about MDD depression, but you're blocking dopamine, you're actually blocking the pleasure center of the brain, right? So you don't really want to give someone a D2 antagonist only, like Haldol, right? There's a reason why we don't give Haldol as an adjunct for depression. We do give Risperdal, but realize that when you give Risperdal or Risperidone, I'll use Risperidone, it's generic, for depression, it's at very low doses, right? You don't hit someone with like no more than 2 milligrams of risperidone as an adjunct. Once you go above 2 milligrams, it's actually very similar to Haldol. So if you guys don't know the history behind Haldol and risperidone, they're actually related because the guy who created risperidone synthesized ritanserin, which is a potent 5-HT2A antagonist, and haloperidol. When he combined it, that's the story of risperidone. But what happens is once risperidone gets above a certain dosage, usually above 2 milligrams, it's very similar to Haldol, the way it hits dopamine. All that other stuff like 5-HT2A antagonism, 5-HT2C antagonism, 5-HT3 antagonism, all that other stuff, it starts losing that affinity for those receptors. So we don't really, unless someone maybe is a rapid metabolizer, right? Because then technically their body's eating it up, even though you give them 10, it's 2. Does that make sense? But for someone who's a regular metabolizer, you don't really go above 2 milligrams. Now, to touch on those receptors, the ones that are important in MDD only, right? This is MDD I'm talking about. 5-HT2A, right? 5-HT1A, partial agonism. 5-HT2C, 5-HT3, 5-HT7, alpha 2 blockade. All right. Again, 5-HT1A partial agonism, 5-HT2A antagonism, 5-HT3 antagonism, 5-HT2C antagonism. All right. 5-HT7 antagonism, which is the newer medications like Trintellix, vortioxetine, or lorazepam, Latuda. All right. Those are some of the significant medications. So you're adjuncting. So let me give you a good example. You're giving someone for MDD, right? Their first trial. Um, I don't know, pick one. What would you give someone? If I was depressed and they came to your office, what would you offer me? An adult. What would you offer me?
Sertraline.
Sertraline. Very good. All right. And how would you sell it to me? Right? Quote unquote, you're telling me I'm gonna take sertraline. How is it gonna work for me? What is it gonna do? It's gonna increase.
Increase the serotonin.
Very good. Okay. And in theory, what is the increased serotonin supposed to do?
Increase your mood,
But
like make your mood better.
Okay. Yeah, you could. But what's the mechanism? How can you, so Nature magazine apparently had the controversy, was it 2 or 3 years ago, in which they released that big paper and quote unquote it debunked the monoamine. I'm sure you guys heard about it. It was all over the place, right? It supposedly, even though I have my arguments about that, it debunked the neurotransmitter deficit theory of depression, right? Look, any decent psychiatric provider doesn't believe that that depression is caused by not enough neurotransmitters. I hope you guys don't believe that either. Someone who's, I don't know, Because I'll say I won't say nothing bad about them, but anyone who believes that, you probably shouldn't see them. All right. So depression is very complex, right? We're kind of understanding it now, but one of the theories could be inflammation, right? Which is why they're studying GLP-1 agonists now, and it's kind of helping, right? Where sometimes people even do some blood testing. They do. How do you test someone for inflammation? What are some of the blood testing that we order? Test for inflammation. Do you guys know?
ESR and CRP.
I'm sorry. Say it again.
ESR and CRP.
Okay, Cedrate, yes, Cedrate is a very easy inflammation test. You know why? You know how to do Cedrate level? You know how they do it? They draw blood and they leave it there and it just sits there. No machines needed. And you just time how long it takes for the blood to clot. All right? Very easy test. CRP, C-reactive protein also. So one of those tests that we do is there was a correlation at one time in which if someone had elevated CRP, there was a belief that they might not respond to serotonin reuptake inhibitors, all right? Because for whatever reason, their form of depression was due to excess inflammation. So there is a lot of studies now showing that if someone's BMI is above, right? Let's say someone has a BMI of, I don't know, 28 or above, that they might not respond to antidepressants, but as they start exercising and they reduce their BMI, they actually respond better to the medications. And they're actually doing studies now in which people are giving medications to drop that, like GLP-1 agonists. And once their BMI regulates, they actually respond better to medication. All right. Is it the GLP-1 agonist that's causing the antidepressant property? Is it them losing the inflammation in their body that's causing it? Nobody really knows, but it's interesting. So going back to what I was talking about before I got sidetracked, I'm sorry. So sertraline, good option, not bad. Serotonin reuptake inhibitor, but the problem is, as you guys know from the book, there's numerous serotonin receptors, right? If you hit some of those receptors, sure, it causes good things. It could cause the release of neurogrowth factors, right? Like brain-derived neurogrowth factor, which increases synaptic plasticity, right? So new connections will grow, especially in the hippocampus, which usually degrades during depression. But what happens if it hits the wrong parts? It hits the wrong serotonin receptors, right? It can cause sexual dysfunction, it can cause weight gain, it can cause apathy, it can cause suicidality. So there's many other receptors that it can hit that can cause side effects. So how can we address that? By giving antagonists, right? Because you don't want to just have a broad serotonin release all over the body, because what happens is sometimes people might have more sensitivity to the side effects before they get the relief from it. So what we can do sometimes is we can give them specific medications to block those receptors, like trazodone. Let's say, for instance, you give someone a sertraline, right? It increases serotonin everywhere. And sometimes what happens is during your sleep cycle, which we'll talk about in detail when we talk about sleep-wake disorders, right? When you're in deep sleep, your serotonin levels actually drop at that point when you're sleeping. But when you're taking serotonin reuptake inhibitors, even when you're up at night, the serotonin is going up, so that can manifest as nightmares, a decrease in your deep sleep, so you wake up exhausted, you feel tired, or sometimes even insomnia. So sometimes it happens that patients are like, yeah, I feel better, but now I can't fall asleep since you started that sertraline. Not that it made them manic, not that it caused early activation, but that extra serotonin that you're giving them is actually messing with their sleep cycle. Does that make sense? So what could be a medication I can give them that can help with that? It's a pretty prescribed hypnotic that we use. What's the medication? It's a 5-HT2A antagonist. It's a 5-HT1A partial agonist. It's a SPARI. It's considered a SPARI. Stahl calls it a SPARI. What is it? That's what it's very trazodone. Yep, trazodone. So by giving someone trazodone at bedtime, right? It's a 5-HT2A antagonist. It's going to block some of those 5-HT2A receptors that normally the serotonin will bind to, which downregulates dopamine and also can affect your sleep, right? So what happens if you hit too much 5-HT? Because I already told you guys before that a 5-HT2A antagonist increases dopamine, right? So what happens if a 5-HT2A agonist hits dopamine? It's going to downregulate that dopamine and cause flattening. Well, have you ever seen patients say, I took an SSRI and I feel like a zombie? I feel like I have no emotion, I have apathy. So it's induced by the medication, actually. And then at the same time at night, they're going to have insomnia because it's hitting those serotonin receptors. So you give them a 5-HT2A antagonist like trazodone, or what's another one? It helps with appetite. We talked about it last week. That's with an M. Mirtazapine, right? That's another option you can give them also. All right, so mirtazapine. But I normally wouldn't give mirtazapine unless a patient has what as a symptom of depression. what?
Lack of appetite.
Very
Or
good.
appetite?
Very good. And what receptor helps with that? What is the one that helps with nausea and helps with appetite? 5-HT what?
3.
Very
Three.
good. 5-HT3. Similar to Zofran, right? Isn't Zofran 5-HT3 antagonist? So think of it as like a built-in Zofran. And remember, some side effects of sertraline are what? Nausea. So if someone has a lot of nausea from the sertraline, also has low appetite, also suffers from insomnia, why not give them mirtazapine? So it is a tough sell. I know in the beginning patients are like, but I only want one medication. Can you just give me sertraline? Of course, you can tell them, my job is to educate you on what the risks and benefits are. Ideally, I do want to give you one medication, right? But sometimes one med is not going to be enough because it's going to be a broad spectrum medication. It's going to hit different things that you might have to, if you can't reduce the dose and help you, maybe you might have to adjunct something, all right? So polypharmacy, I know is a big problem, especially in psychiatry or other parts of medication. So I'm definitely not for polypharmacy unless it's called rational. Some people use that term, rational polypharmacy. So there's no redundancies, right? You're not giving someone multiple anticholinergic medications. You're not giving someone the same antihistamine. You're not giving someone clonidine and guanfacine at the same time. I'm sure you guys have seen that before, right? Or someone's on propranolol and metoprolol at the same time. Like, would you ever see a cardiologist give someone two beta blockers or three beta blockers at the same time? It doesn't really make any sense, right? Because it's similar mechanisms and you can just maximize one medication. All right. Do you guys understand what I'm saying now with like adding medications? Evan, did I answer your question?
Yes, and I think I had one more question that's kind of a good segue into this. So the 5-HT3 and 5-HT7 receptors, to me, I know there's a difference, but they sounded very similar in how they work to me, is that they both inhibit GABA, which increases glutamate, which increases downstream neurotransmitter release. But is there a difference between how those two work or where those two work in the brain?
Yes, we're going to touch on that when we talk about schizophrenia.
Okay.
All right. But yes, there's a little bit different. There's a little bit of difference with them. Yeah. They're both in GABA interneurons, but remember, it also depends on what part of the brain that it's in. Is it in the frontal lobe? Is it in other parts of the brain? So it gets a little confusing, but I like your logic there. That's good to ask that. Yeah. There's minute details that might make a difference with specific patients. All right. Everything is in the details. So it's important that when you guys start prescribing, that you guys are very, you scrutinize every medication you're giving patients because you don't want to give someone a medicine unless there's a reason for it, right? Like when I say like, try to match even though it's hard sometimes, match the best clinical profile of the meds with the clinical profile of your patients, right? So if someone has insomnia, poor appetite, and is depressed and is afraid of sexual dysfunction, mirtazapine might be a good option, right? If someone has issues with insomnia and has had sexual side effects of medication in the past, maybe trazodone. If they've had a history of priapism on the medication, maybe trazodone might not be an option for them. Get it? So you also want to mitigate risk of the medications. It's like giving someone lithium and they already have impaired kidney function. You understand? So you want to make sure that the medicine matches the risk. It's always risk benefit. There's no medicine that you can give somebody that's all risk. That's all benefit. I mean, no risk, right? There's always a little bit of risk or medium risk. So it's up to you as a professional to make sure that you balance out those risks and you do adequate, blood level dosing. So we don't use. There's really not many blood levels that are needed for SSRIs, right? Except one. There is something we have to check because SSRIs can cause that, which can lead to seizures. What is it? What do we check? I don't want to make it too easy, but what panel do we order? And what do we look for in that panel?
Electrolytes.
Okay, very good. And what is the panel called? What is the blood test called?
BMP.
Very good. Basic metabolic panel, all right? Or Chem7. So Chem7 is the basic one, or you can do Chem20, which is going to show the more. I usually do Chem20 because it shows me liver and kidney functioning on there also. All right, so what would you check for? Which electrolyte?
The UN
Calcium.
creatinine. Sodium.
Sodium.
Sodium, very good. Sodium. All right. Because what? SSRIs, especially in older patients or very young patients, can cause what? Hyponatremia.
Hyponatremia.
Very good. Hyponatremia. All right. So you guys remember what the levels were for sodium? What is it?
Like
35 to 145.
135.
Around there, yeah, 135, 52, 135, 45, around there. Exactly. Yeah. So a lot of times what you do is, so remember, one blood work by itself is not really going to help you, right? So you need to do longitudinally check it because it might be okay, you might be normal, but then let's say it's 143. You take it 3 months now it's 138. Then he goes down to 137. So you kind of see it trending down, so you have to address it right away. Right? So a lot of times our labs are really only significant if you do it over time and you kind of see the trend. That's why a lot of the EMRs, they give you the number, but they also give you the trend, right? You see the line graph of how it goes up and down, which is important because you'll see it. All right. And if it's raising, if it's going up, that might not be good either. All right, depending on what the value is that you're looking at. All right. Let's say someone's on lithium and you see, calcium levels going up. That could lead to hypercalcemia. All right. Okay. If someone's depressed and their main symptoms are low mood, inertia, low motivation, and they don't want to gain weight, what would be a good option for them? I don't want to chime in.
Wellbutrin.
Very good. And how does Wellbutrin work? What's the mechanism of action of Wellbutrin?
It inhibits norepinephrine and dopamine
Okay.
reuptake pumps.
Very good. And what's significance of increasing dopamine norepinephrine? Let's say you're increasing norepinephrine. What symptoms does that target and what'll get better?
Fatigue, low motivation.
Okay. Very good. What are some things you should look for then, since you're increasing norepinephrine? Every time you see me, what should you check?
Blood pressure.
Very good. All right. Hypertension. What about if I'm having some pain, neuropathic pain, and I'm also having low energy? Well, what class of med do you prescribe me?
SNRI?
SNRI, right? Give me an example of an SNRI you might use for me. That's good. That's used for pain sometimes.
Duloxetine?
Very good. Duloxetine. All right.
Quick question about that.
Yes.
If duloxetine is prescribed for pain, why isn't venlafaxine?
Good question. Because the ratio of the amount of norepinephrine that inhibits is very different. So on average, the ratio of serotonin reuptake to norepinephrine reuptake on Effexor, right, venlafaxine, is 30-1. So for every 30 serotonin receptor that hits, only hits one norepinephrine. So that's why sometimes you'll hear people say that if prescribing someone Effexor less than 125 milligrams, it's very similar to a serotonin reuptake inhibitor. It's not until you go above that dose that it's become significant norepinephrine reuptake pump, and that's actually going to help those symptoms. Does that make sense? You have to go higher.
Yeah. So
Now,
do they give Prestique for pain since that's more net inhibition?
it's expensive. It's expensive, so I don't think so. It's expensive.
Okay.
It's a cost thing. Yeah, duloxetine is 10-1. So with Cymbalta, duloxetine, for every one norepinephrine is 10 serotonin. I'll make it easier. 10 serotonin, it's one norepinephrine, so it's a little bit better, right? Levomilnacipran, I believe, is 1-1 or 2-1. So it's very close, almost even. So that's the reason why. So norepinephrine works that. So you have your dorsal root ganglion, right? Your spinal cord that brings up pain to your brain, so you feel it. So norepinephrine goes down that pathway, so it inhibits it. So it kind of inhibits the pain response. So by increasing norepinephrine, it has downstream inhibition of that pain receptor. So your body kind of feels it dulls the pain. All right. So if someone has chronic pain and they're also having depression, maybe an SNRI might be a good option. The problem with SNRIs, the reason why I don't use them a lot is because getting off them is very difficult, especially Effexor. Effexor is probably the most difficult. I've had patients on that for years and they've tried to get off, but they can't. So there's something called a hyperbolic taper, in which means that, I'll give you an example. I don't know the exact number, percentage, but this is just an example of it. Hyperbolic taper means that if someone's 100 milligrams of Effexor and you cut it in half and they go to 50 milligrams of Effexor, theoretically in your mind, you would think 50% of those serotonin receptors, norepinephrine reuptake pumps are going to get unblocked, right? But it doesn't actually happen that way. Let's say, for instance, if you go from 100 to 50, maybe only 20% of those transport pumps will get unblocked, right? Going from 37.5 to 0, there's a bigger jump, so people have more side effects or withdrawal symptoms. That's why when people sometimes go from 1 112.5 to like 75. They're, oh, I feel great. Can we just go to 37.5 and then stop it? I say, well, the real fight or real battle to get off it is actually 37.5 to 0. Sometimes you have to do every other day dosing, then every 3 days, and every 4 days, and every 5 days, and once a week. Or you have them break the capsule, open it, put it in water, 5 mLs, and you go to 2.5 mLs and 1.25 mLs, then 0.5 mLs, and then you stop it. Because the fact that when you go below 37.5, more of the receptors get unblocked and they have more withdrawal symptoms, brain zaps, flu-like symptoms, fatigue, irritability, insomnia. These are all side effects of withdrawal from SNRIs. All right. Sometimes the technique I use is I bridge them to fluoxetine, which has a very long half-life. So what I'll do is, this is advanced. This is not going to be in your test, but this is just for your information. 37.5, I keep them on that for a little bit. I put them on 20 milligrams of fluoxetine. I let it sit for about a month. So they're actually on 2 medications. What's the half-life of fluoxetine? Give or take.
5 weeks. Well, 1 week
Half-life is 1
half-life,
week. It's steady state.
1 week, and then
Yeah, about a week half-life, but 5 half-lives is steady state, right? When it hits steady state in about 5 weeks, then I stop the Effexor, and then I stop the fluoxetine, and the fluoxetine tapers itself. Get it? So they're on Effexor 37.5 and fluoxetine 20, both those meds for about 5 weeks. Once fluoxetine hits steady state, I stop both medications, and the fluoxetine stays in the system, and it washes out itself. All right? Doesn't always work, especially if a patient's tried fluoxetine in the past and couldn't tolerate it. But if a patient can tolerate fluoxetine, they really want to get off the Effexor, that's the technique you use. Right? You bridge them to a long half-life medication, you stop it, and then it washes out itself. All right? Any questions? So, chronic pain, SNRI. Worried about sexual side effects? Wellbutrin. What's contraindication for Wellbutrin? If someone has what? History of what?
seizures.
Very good. So what could be something you look out for? History of, besides them saying I have a seizure, what other comorbidities might put them at risk of seizures? What is that?
Heavy alcohol use.
Heavy alcohol use is one. What's another one? Teenage girls. I hate the stereotype, but you have to look out for them.
Eating disorders.
Eating disorders, very good, right? Because if they're constantly, well, it depends on the eating disorder. More of the purging eating disorders, right? If they're purging, like binge eating disorder with purging or anorexia nervosa with purging, because the purging is making them lose electrolytes, and that will actually make them, high risk of having a seizure. All right. What else? Head injuries, right? Someone plays contact sports, is a boxer, right? That could also put them at risk. So just be very careful with those patients. And you can combine them. So let's say someone's doing very well on sertraline. Now they're having a little bit of sexual side effects. They don't really want to stop because it's helping, but they also have low motivation. You can stack them. You can give them Wellbutrin on top of that. Actually, there was, I don't know, maybe 20 years ago or 10 years ago, around that time, there was a medication that was combined. It was called Welloft. It was Wellbutrin combined with Zoloft. All right. I think they probably took it off the market because it wasn't making money, because it was probably cheaper just to prescribe both medications separately, right? The ratio was probably a little different, but if you could prescribe them separately, it's covered by insurance, it's going to be cheaper. If you prescribe them Welloft, which is branded, people probably weren't prescribing that. Same thing is happening now with Symbiox. You guys know what Symbiox is? It's olanzapine combined with fluoxetine. You can just prescribe them fluoxetine and fluoxetine and olanzapine, and it's cheaper than doing a prior authorization for Symbiox, which we use sometimes for bipolar depression, and we also use that for treatment-resistant depression. All right.
I read somewhere that people would prescribe escitalopram and buspirone to make vilazodone because the vilazodone was so expensive.
Very good. Yeah, you could. 5-HT. Yeah, exactly. That's why vilazodone is not branded anymore. It's actually generic. Yeah. So tell me, why does the 5-HT1A partial agonist help? How does it help?
It acts like an anxiolytic.
How? What's the mechanism? What's that mechanism of action of buspirone? Buspar. 5-HT1A partial agonist. right? Remember, 5-HT1A partial agonist is very similar to 5-HT2A antagonist. They're like yin and yang. So if you give someone a partial 1A, 5-HT1A partial agonist, it's similar effect as giving someone a 5-HT2A antagonist. All right. We'll talk more about this when we talk about schizophrenia, but the medications that are 5-HT1A partial agonists and 5-HT2A antagonists actually have less EPS than the other medications, like clozapine, quetiapine, right? Olanzapine to a certain extent. But quetiapine and olanzapine are very potent 5-HT1A partial agonists and 5-HT2A antagonists. So therefore, it increases dopamine in the nigrostriatal pathway, which reduces the risk of extrapyramidal symptoms. Does that make sense? Okay.
So now that you said about quetiapine and we were talking about polypharmacy,
Mm-hmm.
when we look at that chart for bipolar and you look at all the medications, and a lot of patients who are diagnosed with bipolar, they're on 2, 3, or more medications.
Mm-hmm.
Why isn't quetiapine used more since it kind of hits, depression, mania, and maintenance?
Yeah, so quetiapine is a good med because it's one of the few meds that's broad spectrum and also has indication in bipolar 2 disorder, right? So remember, a lot of the newer medications have indication for bipolar 1 depression, but there's not many that have been studied in bipolar 2 depression. There's only two medications. I'm going to say the generic, not the branded. You guys know quetiapine is one, which I just mentioned. And what's the other one? Is that what it's called? Lumateperone. We'll talk about that when we talk about schizophrenia. But those are the two medications that have been studied. They have a lot of studies in bipolar 2, right? They're approved in bipolar 2 depression, right? So remember, bipolar 1 depression, bipolar 2 depression are not the same. They might look the same, but they're actually not the same, right? Because bipolar 1 has mania, bipolar 2 has hypomania. And sometimes there's distinctions that one might respond to one and not the other. Okay? To
So
answer your question, Jerry,
cariprazine and lorazepam are approved for bipolar
bipolar
1
one,
depression.
bipolar 1 depression.
Okay.
Yep,
Okay,
bipolar 1
sorry.
depression. Right. I'm not going to trick you guys and put those distinctions right now because it's going to get too complicated and I don't want to confuse you guys. But just know when you're practicing that there's only two medications right now. It might change when you graduate, but as of right now, as of today, as of 2/21/2025, this is being recorded, there's only two medications that I'm aware of in America, quetiapine and lumateperone, that are FDA approved for bipolar 2 depression. All right? But that can change by the time you guys practice. Okay. Answer your question, Jerry, it's because of the metabolic burden. All right. Quetiapine, unfortunately, leads down the metabolic pathway that Stahl talks about, which can lead to insulin resistance, which you might see initially as elevated triglycerides. And then it just, it's tough at that point because once people gain weight, it's very hard to lose it. And then all the comorbidities stack up as we get older. So we try to avoid that with patients. But it could be argued that if you could stabilize someone with monotherapy, quetiapine might be one of the better options, might be, right? As long as they're being followed by a good endocrinologist, if they can manage their weight gain, they're on a healthy diet, and they're able to kind of, I like quetiapine. It is a good medication. It's just long term sometimes it gets tricky. And it's hard to argue, is it the sequelae of the disorder or is it the sequelae of the medication, right? It's really hard to tell. Because even people with bipolar disorder who are untreated, they tend to develop metabolic syndrome anyway. Because remember, sometimes schizophrenia, bipolar disorder, it becomes a dopamine issue. And how do people self-medicate? Through drug use, through eating, through smoking cigarettes, which can lead them down that pathway anyway. So how do you draw the distinction between if I would have let this person alone and let the disease process progress, they wouldn't have developed it anyway, right? But yes, to answer your question, Jerry, yes, polypharmacy is abundant in bipolar disorder because remember, there's so many aspects of the disorder. There's lack of sleep, there's low motivation, there's depression. If they have mixed features, they could be irritable, they could be aggressive, they could have psychosis, right? They can have low energy, they can have ADHD-like symptoms. So it's hard to target all these symptoms to get someone functioning with one medication. So sometimes it's one of those things that you try your best to manage with as few medications as possible, but that the chance to stabilize someone with monotherapy is best early on in treatment. If someone goes to different providers and they don't do a good job of screening for bipolar disorder, it's almost like you make them treatment resistant as you put them on serotonin reuptake inhibitors long term and not get the diagnosis right. Let's say, for instance, I went to you, Jerry, and you were a new practitioner and you didn't really have a good grasp of understanding diagnosis, and you prescribed me a serotonin reuptake inhibitor. I did horrible on it. I stayed on it for a couple of years, and I go to Evan, and Evan, again, diagnoses me and puts me on Zoloft. But it's not my fault. I mean, sometimes mania is forgotten, or people don't think that it's dangerous for me. So those periods in which I'm not depressed, I feel like I'm doing good. As I finally get so I don't know, do you guys know how long does it take typically for someone to get an accurate diagnosis of bipolar on average? Well, how many years do you think it takes?
About
Like
10
10
years.
years?
About 10 years. Yeah, so that's 10 years of getting the wrong treatment of the disorder manifesting in my brain, similar to untreated diabetes, right? People get their feet cut off, their toes cut off. Um, it's going to be hard to stabilize them on one medication. So if you do a good screening and you catch it early and there's a family history, maybe you put them on a low dose of quetiapine. I don't know, when I say low dose, maybe 200, 300. And it keeps them euthymic as a maintenance, right? Covers mania, depression, and maintenance. So when I'm euthymic, you put me in quetiapine, put me on metformin, I'm able to like diet, exercise, and I'm doing okay. That might hold me for a couple of years or maybe a decade, who knows, as long as they stay on it. But the longer that I wait and I see different people and they don't get the diagnosis right, there's a high likelihood of me getting put on different medications. All right.
Is
Now,
it more is it more though when you're first diagnosing them and you're putting them on just say the one medication and then you're doing close monitoring, like bringing them in every week and like assessing what other symptoms, and then you're adding the another medication in based on what they're feeling from the original medicine?
are you talking about bipolar? Or are you talking about depression or just in
Well,
general?
cause more like we're talking about bipolar. So like bipolar, you're not automatically going to put them on multiple, or you would, or just it's situational depending on what all their symptoms they are experiencing.
So this is why psychiatry is very complicated, and I'm gonna blow your mind right now. All right, ready? So normally, if you don't treat anybody, right, bipolar disorder, the symptoms tend to get better over time, right? If you leave depression, sometimes it lasts for 3 months, sometimes it lasts for 6 months, sometimes a year. And people who suffer from this, they kind of know, well, my depression usually lasts about 4 months or lasts about 6 months. There's a natural progression to it. So this is usually what happens, right? Someone has depression a few times and it gets really, really bad, right? I'm talking about bipolar depression. I'm going to go to Jerry now for the first time, who's a new practitioner. And when I'm not depressed, I feel like I'm okay. And now imagine my depressions historically last about 6 months, right? At the 5 month mark, I'm like, you know what, this is horrible. I need to see somebody. I'm going to go see Jerry. On the fifth month, I go to Jerry. I say, Jerry, I'm just really depressed. Even though Jerry asked me, have you ever been manic? To me, that I feel like I'm normal. I feel like those days that I'm hypomanic, I'm functioning. I don't look at that as like a bad thing. So I kind of not that I'm hiding it from him, but I just say no. I feel okay. I don't have bipolar because even my understanding of bipolar is like what I see in the movie, right? People who are very manic. So Jerry starts me on Prozac, which we know has a half-life of 1 week, which is going to take about 6 weeks to feel better, right? So think about this now. He puts me on Prozac. Before Prozac even hits steady state, I start feeling better because historically my symptoms only last about 6 months, right? So by that time, I come back to Jerry. I say, you know what, Jerry, I feel great. You know what, the Prozac's really helping. I'm gonna stay on it. So Jerry's like, all right, come back in a month, right? Obviously, I start feeling worse again, but I stay in the Prozac. And I go, no, Jerry, I don't think the 20 milligram Prozac's working anymore. Can you increase it? So Jerry's like, all right, no problem. Let's raise it up to 30 milligrams. I leave again. I come back. I feel even worse. Now I'm not sleeping. Jerry's like, you know what? Let's add trazodone. That's what Professor Collado told me 3 years ago, right? Put me on trazodone. Now I'm not sleeping. So that's the cascade. Now someone adds lithium. It's like, you know what? You didn't have that in the first place. You get it? Because you have to ask people when it started and how long it was historically. But sometimes people are poor historians. They don't know how long their depression lasts, right? So that's what happens. You have to like treat it and catch it at the right time to get because and also know that the medications will start kicking in for a little bit of time, right? It'll take time. Like lithium takes sometimes 2 weeks to start working. So that's why it makes it very complex and very complicated. Because if you're only reporting depression and then my depression is going to alleviate anyway, and someone starts me an SSRI, it puts me on that cascade of the wrong meds. And I can't blame the practitioner because they're only going by what I said. You see how it complicates the issue?
Mm.
And then you're chasing something that you're not really sure. And that's why people get put on polypharmacy. Is it MDD with mixed features? Is it bipolar disorder? Now I'm on I'm on the Prozac that Jerry put me on, right? And I don't want to stop it because I felt like it was helpful before. And I told the doctor, don't stop it because when Jerry put me on it 6 months ago, it was helping me. Just add something. Now, Evan adds Abilify. I feel a little bit better, but I'm still having issues with sleep, right? Now I go to Kazaya. Kazaya, I don't like Evan. He's a jerk. He doesn't believe that I have ADHD. Can you give me Adderall? And you do the screening for ADHD. Now you add Adderall on top of it, right? Now they come to me and I say, "Who taught you? Who taught you? I don't know who. Those are my students. I can't believe I passed them. I can't believe they didn't diagnose you correctly and they put you in the wrong medications, right?" You see how it happens? See how polypharmacy kind of it's innocent, but it happens because there's so many factors. And then you find out the person was a chronic alcoholic and never told you they were drinking wine every day. So it's very challenging. So these are things you need to screen for and make sure. Sometimes a washout is good. As long as they're safe, they're not suicidal, there's family involved. Let's do a washout of your meds. Stop it for a little bit, and let's see what symptoms are there. Is it the Prozac that's making me worse, that's activating me because I have bipolar disorder? And stop the Prozac first and see what the symptoms are. Then you can put me on lamotrigine for depression, or I don't know, another medication for mania, lithium maybe, right? I hope I didn't confuse you guys, but I hope you understand the point I was trying to make, that the disease itself has its own natural progression. So sometimes it could be argued, you have a month left in your depression. Are you suicidal? No. Okay. Let's wait a month and you come back. Let me check in with you in a month and see how you feel. Now, when you're euthymic, let's put you in a medication that's going to keep you euthymic on maintenance. That's an option also, depending on if the patient is dangerous to themselves or others and they're high functioning, right? That could be an option too. Let's wait till you're euthymic and then put you on a medication that's going to try to keep you euthymic. Are you depressed? Only depressed? All right, let's put you on a medication that's for depression. And then once you're euthymic, let's keep that medication for depression just in case, like lamotrigine, and put something else. All right. Or you are manic. Let's put you on Abilify to stabilize you. Okay, now you're okay. Let's put you on a stabilizer medication. Right. But sometimes it's a seesaw. You have to kind of like adjust it.
I imagine it's further complicated if they get hospitalized, because then there's a practitioner who's just dealing with that emergent situation, and then they go out in the world and somebody else.
So what happens most of the time is that people are hospitalized when they're acutely manic, usually, or it's very suicidal, right? But let's say they're acutely manic and someone puts me on a very high dose of olanzapine, right, to stabilize you from mania. Now I'm dischargeable because I haven't assaulted anybody. Now I'm sleeping and I go to see my outpatient provider. If you keep that high dose of olanzapine, what's going to happen? Too much, like I said, too much dopamine blockade, you can actually put them into a depressive episode. So when you see them, you actually should go down and put them on something that's, sometimes with lithium too, right? Like initially when someone is acutely manic in the hospital, they'll shoot for lithium level above 1, right? Like 1.1 maybe, or above 1. Once they come to you and they're stable, you should lower that lithium dose. Number one, it's protective of the kidneys, right? And number two, it's less likely to trigger them to go into a depressive episode. So lithium levels that are too high can actually put someone into a depressive episode. All right, does that make sense?
Why is that?
Because lithium at a high level works like a different medication. It's more anti-manic at a high level than it is at a medium to low level. Like low level lithium, which is like 300 or 600 milligrams, is a good adjunct for depression, MDD. You go above that, for whatever reason, it tends to do the opposite. And plus, there's more side effects. All right. So let's talk about lithium because I want you guys to understand how to prescribe lithium. So lithium is one of the few medications that we have in psychiatry that have shown evidence to reduce what? SI. What does SI stand for?
Suicidal ideation.
Suicidal ideation, right? So you can actually use it as an adjunct for patients on MDD who are on SSRIs, and which I've done this a lot. Patients who are SSRIs, they feel better, but they still have a chronic suicidal thought, right? And it's bothering them. They don't have a plan. They don't want to kill themselves, but that suicidality just keeps going through their mind every morning, right? They still want to die even though they're feeling better. I've added lithium to these patients, and for whatever reason, it goes away. It takes time, though. It can take up to a month or longer. So you can add it on top, right? Bipolar depression, and they're having suicidality, lithium would be a good option. All right. So how do you start lithium? How would you start lithium, Evan? You're gonna start me on lithium. Tell me about it. I have bipolar
First,
depression.
first I'd want to take labs and do a baseline TSH, calcium levels, GFR, um, counseling on the drug
Okay.
prior to prescribing it.
So if I come to your office and I'm an adolescent and I have really bad cystic acne, would lithium be a good option for me?
No,
Okay. What about if I have psoriasis, really bad psoriasis, skin issues? Would lithium be a good option for me?
no.
Probably not. All right. Now, if lithium is the only medicine that's going to help me, sure, it's risk benefits. But is a teenager really going to stay in lithium if they have to go to prom in 6 months, right? So it's sometimes you have to balance that out. Okay, so you start lithium, right? You start me at 300 milligrams. Actually, would you start me at 300 or would you start me at 600? What do you think? Or would you start me at 450? How would you start me? Outpatient. Let's talk about outpatient. Outpatient's a little bit more practical. How would you start me on lithium, Evan? You write me a script for what?
All the labs are normal.
All labs are normal. So we're ready to prescribe lithium. How would you start it for me?
On an outpatient basis, I would probably prescribe 300 because
Okay.
there's less monitoring than if someone was inpatient.
Okay, so when do I take it? Do I take it in the morning or take it at night?
At night to give the kidneys a break because
Very
it
good.
lasts 12 hours or whatever, so it gives a 3-hour break for the kidneys
Good. And when are you gonna draw labs?
prior to
Let's say I started
taking
taking
it.
it on Monday. When would you send me for blood work? I started taking it on Monday.
A week.
Okay. You write me a script to do labs when?
On Monday morning.
Okay. What time? What time Monday morning should I go to the lab?
Should go, let's see, if you take it at night before bed, say you go to bed at 9, maybe like noon.
12 hours. 12 hours. 12 hours after your last dose.
Okay.
12 hours after your last dose. All right. All right. So you do a lithium level, and my lithium level is
Oh,
0.4. What do you do
yeah,
next?
the kids are still up. All right, okay.
All right,
Are
put them to
you
sleep if they're still up.
are you manic?
I'm depressed.
You depressed? I'd raise it.
Okay. So what would you prescribe me now?
Probably 450.
On top of the 300?
No, altogether.
Oh, so you only raise it by 150?
Yeah.
Okay. Now I'm saying that I'm having very bad nausea. What do I do?
I don't know.
Take it with food. That's the easiest one, right? Take it with food. It's not
Okay.
effective absorption.
Easy enough.
Okay. I'm still having really bad nausea. What do you recommend?
Give Zofran.
So let's say you prescribe me immediate release, right? You could, but I would wait. I would try to do them out. I forgot to ask you this
Your
first.
DR?
I would do ER, right? So if you do IR first and they're having nausea, switch them to ER, extended release. All right. Now the thing is, regular lithium, right? It's usually absorbed in the proximal area of your small intestine, right? The ER is absorbed a little bit further down, so therefore it's going to have less of the nausea, which affects your stomach usually, which is proximal in your small intestines, right? So more distal would be the ER, but the side effects would probably be a little bit more diarrhea. All right, let's give or take. Do you prefer nausea? Do you prefer diarrhea? Evan, do you prefer diarrhea? You prefer nausea?
As a provider or individually?
Individual. What's worse for you? Diarrhea or nausea? What do you want to
Um,
tolerate?
I'd probably rather diarrhea.
You probably diarrhea. Okay, so I would prescribe you ER. So this is a conversation you should have with your patients, right? I'm going to prescribe you lithium. Why you prescribe? Because it's a medication that might help you with your suicidal thoughts. It's one of the few medications in psychiatry that are, that have been studied to show that. Also, long-term outcomes have shown that lithium long-term is actually one of the few meds that makes people feel like they're not medicated. Like patients with bipolar could be on atypical antipsychotics, but they feel medicated, right? Have you ever seen patients on antipsychotics? They're slow, they have neurolepsis, they might feel sluggish, they might have like, some dystonia, akathisia. Those are side effects that lithium doesn't cause because lithium's not a D2 blocker, right? Lithium has other side effects. It can cause thyroid issues, it can cause kidney issues, but you're monitoring it. But it's one of the few meds if you can fine tune it and put it at a good level, the long-term outcomes tend to be better. All right. So you have to try to sell it to patients because there is a stigma behind it. And I feel like lithium is underprescribed, right? Because obviously a lot of the drug reps are going to come to you when you're practicing and say, hey, I have a brand new atypical antipsychotic. It's approved for all these indications of bipolar. Stop using lithium because it's an old medication, right? That's lithium still, that's what I don't like to use that term, but there's a lot of guidelines that call it the gold standard, right? Because it is one of the few meds that when patients take it and you keep it at a good enough level, they don't feel medicated. All right. So now, Evan, I'm going to ask you that same question. I prescribe it to you. If you tell me diarrhea is something you want to tolerate, I'll say, okay, I'm going to prescribe you the extended release version. All right. If you tell the opposite, nausea is something you don't want to tolerate, then I'm sorry. If diarrhea is something you want that you can't tolerate, or you want diarrhea, you don't mind.
I don't want either, but
Yeah. You don't mind having diarrhea?
over nausea, yeah.
Okay, then I will prescribe you the ER version. All right. And I'll explain to you that it's metabolized, absorbed a little bit further down the digestive tract. All right.
Can we give something for the diarrhea?
You could. Sometimes the diarrhea from the lithium is transient, which means that it gets better over time. The thing is, you don't really want to over-medicate people and put them on too many medications. So maybe start slowly and you escalate it slowly, and then sometimes those side effects are mitigated. All right. So you raise it up until the patient is better. Now, sometimes, remember, blood levels are just guidelines. So if someone is stable on 300, let's say Evan put me on 300 and my level is 0.4, but now I'm not depressed anymore, would you still push it up? Yes or no? If I have no more symptoms, I feel better on 300 and 0.3. Would
No,
you, yes or no?
no.
No. Good. Because remember, that's just the guideline. So if I'm not responding to a lower dose and I'm below what the guideline is, then yes, push it up, of course. But if someone responds early, keep it and document that. Patient's doing well on 300 milligrams of lithium. Last lithium level was done 0.3. I'd probably recheck it again just in case. Because what can cause a lithium 0.3 level? If I did blood levels too early or too late?
Wait.
Too late, right? Let's say I missed my bus and now I got to the lab an hour later and the medical assistant was like, can you wait a little bit? We have two people that are before you. And now I do my blood work 15 hours or 14 hours. Of course, it's gonna be a false low level, right? It's probably gonna be higher than that. So you also ask the patient, it looks like it was low. What time did you get your blood work? And look at the stamp when it was drawn, right? Usually it'll say when it was drawn. What time did you take it last night? So don't just look at when it was drawn. Also ask the patient when they took it that night. Sometimes you'll see patients have high low level. Let's say like someone's on 1,200 milligrams of lithium, right? And they come back and their level is like 1.1 or 1.2, and they're asymptomatic in my office. I'll ask them, did you take the lithium too late that night? Did you take it at like 12 midnight? Oh yeah, I went out with friends and I got home at like 1 a.m. and I forgot I took it. So make sure you tell patients that. We're doing blood work on Monday morning. Please make sure you take it at 10 a.m. Sunday night because I expect you to do the blood work. If you go to bed later, for whatever reason you forget, then just postpone your blood work. Do it the following day. Right? Because then it's a waste of resources, right? Their insurance is still going to pay for it. And it's a waste of their time because they're going to go and the level is going to be abnormal, right? You can't do nothing with that. All right. So ask the patient, make sure you clarify that. Okay. So lithium, blood draw a week later because the half-life is about a week. Do a level. What's normal lithium level? What is it?
0.6 to 1.6.
Very good. Okay. Let me teach you a simple trick to remember blood levels of carbamazepine, Depakote, and lithium. Half a dozen to a dozen. All right. Carbamazepine, 6 to 12. Easy. Depakote, 60 to 120. Lithium, 0.6 to 1.2. Obviously, each lab is going to have their own variables in that, but if it's close to that, that's the level. All right. So carbamazepine, 6 to 12 nanograms per ml. Depakote between 60 and 120. Lithium, 0.6 and 1.2. If you can remember that, you can estimate if the blood level is close enough. All right. Okay. Make sure you check thyroid, TSH levels. Sometimes I do a test, a panel. It's called TSX with reflex. You know what that means? What does TSX with reflex mean? What do you think? What's the reflex? It means that if the thyroid TSH is abnormal, it's going to reflexively do a T3 and T4. All right, that's what it means. So the reflex means that if there's abnormal TSH, it's automatically going to do T3, T4. All right. If the TSH is abnormal and it's elevated, that could be a sign of hypothyroidism. All right. I would probably send them to primary care just to let them do the rest of the workup. But you're not going to treat her anyway. So you're better off just having primary care on board. All right. Any questions with that? Check calcium. Yes.
I just have a quick question about the GI stuff.
Mhm.
What if they had like Crohn's disease or like they were like on immunosuppressants or stuff like that? Would you still give them lithium?
You would, yeah. I've had patients with the Crohn's on lithium. I would, yeah.
Okay.
I make sure that I'm working together with their primary or their internist or their gastroenterologist, whoever it is. Because remember, lithium has no alternative, similar to clozapine. There's no other med that has its same mechanisms, that has the same benefits that we know at least behind it. Right. And if anything, immunosuppressants, lithium actually increases your immune system. It stimulates your white blood cell count production. Right? It stimulates CSF, colony stimulating factor, in your bone marrow, which increases your white blood cell count. Not that patients could stop their medication and but okay. Any other questions? Depakote. The thing about Depakote, know about it, is very important, is that it is contraindicated in pregnancy, and make sure you document that you counsel a patient that they should be on birth control if they're on Depakote. All right, because that'll be a big malpractice suit. So normally I don't prescribe Depakote unless, especially a woman who's like has a history of psychosis or erratic behavior, because what if the med stops working and they get pregnant, God forbid, right? So you have to make sure that there's an implant or they have an IUD or something that prevents it. All right. My boyfriend pulling out is not good enough to document that in the chart. Okay. So Depakote is a good medication, but it could be toxic to your bone marrow. It does suppress bone marrow too. It can lead to neutropenia. And it doesn't really cover depression. It's not a very good antidepressant. So it's not going to cover for if someone becomes depressed, you're going to have to add something to the Depakote. Now, it's very important. What happens if someone's on Depakote and you add lamotrigine? What do you need to do with the dosing for lamotrigine? Very
Cut
important.
it in half.
Half it.
Cut it in half.
Yeah. So some guidelines say cut it in half and dose it half the amount of time also. So half the dosing. So instead of doing lamotrigine 25 in 2 weeks, it might be lamotrigine 12.5 in 4 weeks, just to be extra safe. All right. So half and double the titration schedule. Now make sure that, let's say for instance, someone's not liking the Depakote and they're on lamotrigine Depakote, and you stop the Depakote. What should you do to lamotrigine? You should what? Increase it or decrease it?
Increase.
No.
Actually, decrease. Sorry. Decrease.
Decrease it, yes, because then the lamotrigine levels are going to go up. All right, because it has nothing to do with the CYP enzymes. It's the UGT system. It's phase 2 metabolism. All right, we don't have to go in detail about it because I don't want to confuse you, but there's different types of metabolism. All right, phase 1 and phase 2. It just makes the molecule a little bit more watery, so that your kidneys can excrete it. All right, so it's a UGT system. They both compete with that same UGT system. All right, so someone's in Depakote, you add lamotrigine, you have to half the lamotrigine. All right, half. I think there was someone who was doing memorable psychopharmacology. You watch those videos on YouTube when I was a student. It's called memorable psychopharmacology. He had the mnemonic Valhalla, right? Because you know what Valhalla means? It's like it's like heaven for Norse mythology, because if you don't do that, you're going to send them to Valhalla, they're going to die. So Val stands for valproate. Ha stands for half. La stands for lamotrigine. So val, valproate, half lamotrigine. Valhalla. If you don't do Valhalla, you're going to send them to Valhalla. All right, if you can remember that. Valproate, half lamotrigine. Unless you don't like the patient. Yeah, it's all right. Just kidding. Okay. Any questions with that? Carbamazepine, we still use Tegretol. All right. Trileptal, we still use arcabazepine. Right? Just know with those that they can cause hyponatremia also. They're both, well, carbamazepine is a very strong inducer. So if you add carbamazepine, you can actually, half or even decrease more than that the blood levels of some medications. So make sure you have to make adjustments. And obviously, when you stop the carbamazepine, you're going to have to reduce the dose of those medications, right? If you put carbamazepine on board, your serum levels of the meds are on now, because it's an inducer, it's an increased CYP enzyme is going to go down, right? So when you stop the inducer, you're going to have to reduce the meds because it's going to shoot up. All right? Does that make sense? So this is being recorded. You can just rewind that part. All right, carbamazepine is inducer. If you stop the inducer, you're going to have to reduce the medications. All right? Remember, induction is slower than inhibition, right? So if you start someone on carbamazepine, you have to do the carbamazepine levels at least 10 days after you take it, right? It's going to take up to 10 days or more to induce those enzymes. They're going to reduce the blood levels of carbamazepine. That's why you have to check its levels. If you start someone on Prozac, by the next day you're inhibiting it, all those drug levels of other medications are going to go up already. Inhibition is quick. Inducement is slow. All right? Inhibition is quick. Inducement is slow. So if you take, chamomile tea that night before, all those 3A4 medications are going to go up. All right? You drink grapefruit juice for the next 2 or 3 days as it stays in your system, it's going to go up. All those 3A4 medications. All right? You take an inducer like carbamazepine, you're not going to see that until a week of them taking carbamazepine. All the blood levels are going to drop. All right? You smoke cigarettes, you keep smoking cigarettes, it's going to take a week or more, or 10 days for the 1A2 induction to decrease your levels of the medication. All right? You drink caffeine, your blood levels of 1A2 are going to go up. We're going to talk more about that when we talk about schizophrenia. And is that a pharmacodynamic or pharmacokinetic interaction that I'm talking about?
Kinetic.
Pharmacokinetic. Right, pharmacokinetic. Very good. All right. Last half hour. Any questions?
Can you explain the carbamazepine? You said I know it's like it's an inducer for all of the 3A4 meds.
Mm-hmm.
But if you take the carbamazepine in 7 to 10 days, you might see what happened in the blood, like in the
Whatever
serum.
medicine that you're on, the levels are going to go down because inducing means increasing, right? When you induce it, you're increasing the CYP enzymes. So what happens when you increase the CYP enzyme? It's going to eat up all those other medications, so the levels are going to go down.
Yeah.
So make sure you read the question. So this is important. Make sure that you read the question and don't just answer it quickly, because the question could be, what happens to the CYP enzymes? If I'm asking you, what is carbamazepine doing to the CYP enzymes? The CYP enzymes are going to go up, right? If I say, what is it going to do to your medication regimen or the specific medication, what's going to happen? It's going to go down. So those are important concepts. Your CYP enzymes are going to go up. Your medication levels are going to go down.
So you'll increase the dosage of the medications.
Yes, if they're on carbamazepine.
Yeah.
Correct. Yes. All right. Now, if I stop the carbamazepine, you're going to have to reduce those doses of the meds, because what's going to happen is they're going to spike up because it's no longer inducing those CYP enzymes. All right.
Do you usually decrease the dose of other meds before starting carbamazepine? And
It depends on the medications on what the patient's presentation is. So if I'm worried that the patient is going to become manic, then no, I wouldn't, because I want to keep it on there and decrease it slowly. If it's something that's, I don't know, a hypnotic or something, then yes, I would decrease it right away. So it depends on what the medication is and what it's supposed to do to the patient. Yeah. If someone's on lithium, and you can be on lithium and carbamazepine at the same time, and you stop carbamazepine, what do you do to the lithium? What CYP enzyme metabolizes lithium? Zero, none. You don't touch the lithium. All right, that was a trick question. Lithium is not metabolized by your CYP enzyme. That's where there's not many drug-drug interactions with it. So you don't have to adjust it. All right. See why it's important to know all these pharmacokinetic stuff? If you don't know, you can look it up. Sure, you can go on Hippocrates and look it up, or go on Medscape or do other stuff, whatever it is that you guys look at, right? But if you know it, it's faster.
So in Stall, it talks about valproate and carbamazepine, and it talks about the mechanism of action being different. But I thought they both blocked sodium channels and potassium and calcium channels. Do they do that differently, in a different way?
They're a little different. They're a little different. Yeah. I don't want to confuse you guys now, but just know that Depakote tends to be a better medication than carbamazepine. All right. And we tend to use that more. Carbamazepine tends to be reserved to like second or third line because it messes up the regimen of the patient that the patients are on already. Like we talked about before, right? Many bipolar patients who are, once they make it to you, they're already on 2 or 3 meds. If you start carbamazepine, it gets very complicated. You have to make adjustments to the medication. And then what happens if they miss a few doses of the carbamazepine? Now those are the patients that are calling you and saying, "Hey, I'm having side effects with my risperidone." Why? Is it because you stopped your carbamazepine, right? I went on a vacation. I forgot my bottle of carbamazepine, but I only have my 4 milligrams of risperidone. Now I'm in Cancun, Mexico. What do you want me to do? What would you tell me, Evan?
I don't know.
You have
Go to the pharmacy in Mexico. I don't know.
See, I'm just saying it gets complicated. And you shouldn't be giving advice overseas anyways. You're not licensed there, but it's just I just wanted to make a point that it gets complicated. It gets complicated. Which is why I tend to avoid carbamazepine. And if you add carbamazepine to SSRIs, what are you compounding? The risk of what? What side effect?
Hyponatremia.
Hyponatremia, right? So know that too. Whenever you add medications that have similar side effects, you compound it, right? Like if you add Depakote to clozapine, you compound the risk of dropping your white blood cell count, right? We'll talk more about that in schizophrenia, but when you add meds that cause nausea, multiple meds that cause nausea, there's a higher likelihood of them having nausea, right? You combine meds that cause this, there's a higher likelihood. Like if you put someone on Wellbutrin and a stimulant, it's probably going to cause insomnia or activation. Not, I've done it before with patients, but just know what the risks are. You seem like a very anxious person. You're already having insomnia. I don't think it's wise to add Wellbutrin to your Adderall. And then you have to explain to them what your rationale is, right? Unless you want to add an hypnotic at bedtime, but then you're kind of adding stuff to. Nothing wrong with it. There's some patients like that, but you kind of let the patients know if we add this and this, then we might have to add that. And they say why? Because most medications are causing this, right? But good questions. Any other questions? So I have a history of abnormal EKGs. Would you prescribe me Lexapro? Why or why not?
No.
No.
Because it causes QTC prolongation.
Very good. So I wouldn't prescribe that to a patient, right? So sometimes you go to patients, so you give them a couple options, right? So I'll say we can do sertraline or we can do Lexapro. First episode MDD, right? I make sure I ruled out bipolar disorder. There's no family history. There's no substance use. And I'm pretty confident that this is MDD, right? First time. and you're an adult. I'm giving you two options, Lexapro or sertraline. But let me ask you a few other questions. Do you have a history of abnormal EKGs? Do you have a family history of cardiac problems? Do you have a history of OCD? Do you have a history of PTSD? Do you have a history of irritable bowel syndrome? Do you have a history of Crohn's disease? So based on these answers, if they have more GI side effects, I would probably lean away from sertraline, right? If they have more cardiac problems, I might lean away from Lexapro. If they have neither, then it's a fair option. But usually what I do is the deal breaker is any history of intrusive thoughts or OCD. Why? Usually with OCD, we have to dose the SSRIs higher, right? So I don't really want to go above 20 milligrams of Lexapro because there's a higher risk of causing QTC prolongation. But I'm comfortable going super therapeutic with sertraline, which I have. I've actually put patients with treatment-resistant OCD, which we'll talk about when we do OCD next week, on anxiety disorders, on 400 milligrams of sertraline, which is double the FDA indicated dose, right? But there's studies for that. There's a term I like to use called OLWE. You know what OLWE stands for? OLWE. What do you think it stands for? OLWE. It's not a supermarket. It stands for off-label with evidence. Off-label with evidence, all right? So if I say something is OLWE, that means that you can look it up on PedsMub, you can look it up on all of, CINAHL, all those databases. It'll show you studies that show that the medication is, an example would be lamotrigine, right? Is lamotrigine FDA approved for bipolar depression, Evan? What do you think? It's not FDA approved for bipolar depression, right? That's a trick question. It has evidence, though. If you look it up, you put lamotrigine bipolar depression, there's many studies that substantiate it. So it will be OLWE, off-label with evidence. So you can prescribe it. It's off-label, but there's evidence for it, so it's okay. So with sertraline 400 milligrams, it's off-label, obviously, it's above the 200 milligrams. But if the insurance company was like, why are you prescribing over? I would send them the studies that show that super therapeutic doses of SSRIs are effective in treatment-resistant OCD, right? I don't want to add an Abilify. I don't want to add an atypical antipsychotic, right? They have metabolic symptoms. So I want to try this first. I want to go higher on in the sertraline because there's evidence that shows that it could be effective in treatment-resistant OCD. Get it? So I wouldn't use Lexapro because I wouldn't want to go above 20 milligrams of Lexapro because then I'm going to put them at risk of QTC prolongation. I could do that with sertraline, but I wouldn't want to do that with Lexapro, all right? Or Celexa, which is even worse. Even though they're active metabolites, they're enantiomers of each other. Celexa tends to be worse actually with QT prolongation for whatever reason.
I have a question with heteroreceptors. So is there heteroreceptors for each monoamine on every receptor? Meaning, is there on the 5-HT2C receptor, is there a heteroreceptor for norepinephrine, a heteroreceptor for dopamine, a heteroreceptor for acetylcholine on that? And then on A2 receptor, is there a 5-HT2 heteroreceptor and a dopamine? You see what I'm trying to say?
There's a lot of heteroreceptors. So to answer your question, to be honest with you, I don't know. I'm not sure. But I do know there's a lot of heteroreceptors, so I don't want to give a blanket statement. There's one for every, but I'm assuming there might be, but I can't say it here on YouTube that yes, there is, because there might be maybe a few that aren't heteroreceptors. But it seems like there is, so that's the accurate. But I guess the ones that are clinically significant, the ones that are listed in the book, the ones that are emphasizing right now are the ones you should know, right? Like the alpha-2 heteroreceptor on the serotonin neuron, right? That's significant. The 5-HT2C and the GABA interneuron, right? An NMDA receptor on a GABA neuron, right? Because we use that for treatment resistant. That's what ketamine does. So those are significant. We're not going to talk a lot about, I'm saving this for when you guys get to the clinical part. When you get to 5-17-27, we'll talk more about interventional because that kind of opens things up more. I want you guys to have a good foundation on regular psychopharmacology first. But once you start talking about, TMS, ketamine, all that stuff, it gets a little complex. But, you'll build your way up there. But we can't talk about that until you understand what these meds do first, right? You don't want to put every patient on ketamine You want to make sure they actually have adequate trials and regular medication first, even though they suck, right? Based on the STAR-D trials, 33% of patients respond. Another 33% of patients have partial response. Another 33.3 patients have no response. But even then, we don't have enough evidence yet that interventional should be used as the first line, at least at this point, right? I could be proven wrong in a year or so. I'm not sure, maybe. Right, Spravato, we use Spravato also, NMD antagonist. Auvelity, another new NMD antagonist.
Speaking of ketamine, the NMDA, it's a glutamate antagonist, right?
Yes, on a GABA neuron. So what happens is when you block remember, usually glutamate is excitatory, right? So when you block the NMDA receptor on the GABA neuron, it's going to stop GABA from firing, so it disinhibits it. So by stopping GABA, you're actually increasing all of those neurotransmitters. But it's more complicated than that. When you block NMDA, there's multiple receptors for glutamate, right? You have kainate, you have NMDA, and you have AMPA, right? So what you're doing is you're blocking NMDA at that neuron, and you're forcing glutamate to bind to the AMPA receptors. By binding to the AMPA receptor, it causes a cascade that releases nerve growth factors, which increases the sprouting of your brain. All right. So in a way, that's a simple way of explaining it. But you're causing the glutamate to bind to AMPA receptors by blocking NMDA. All right. It's not going to be in the test, so don't worry about it. This is just extra stuff. But see how exciting psychiatry is? There's so much stuff to learn. I'm learning new stuff every day.
But isn't that the added bonus of ketamine is that you actually get that neurite formation and you don't really get
It
that
is, but
with
you can get that with serotonin reuptake. It has been shown.
okay.
It just takes longer. Yeah. So the downstream effects are almost the same, but the thing is you're getting that quicker, right? Sometimes within a couple of days. But you also have cardiotoxicity. It could be toxic to your kidneys, right? Cause neurogenic bladder. It couldn't cause mania or psychosis, which I've seen a few times. So there's risks to it. So you want to make sure that the patient doesn't have a risk that they would be a good candidate for that. There's TMS also, transcranial magnetic stimulation, right? Which tends to be less invasive, but the commitment's a little bit longer. They have to be Monday to Friday for the first month. They have to come in your office. So it depends.
One more question, I promise, then I'm done.
Ask as many questions you want. I'm here till 9:30.
Hey, would you consider venlafaxine a prodrug?
It's a good question. No one's ever asked me that before.
Because I mean, I'm not sure, right? Because I mean, venlafaxine still has action as
So
on
similar,
pill,
yeah. The similar argument can be said about risperidone because risperidone is broken down to paliperidone, 9-hydroxyrisperidone. But risperidone itself has its own different mechanism also. From my understanding, which I could be wrong, my understanding of a prodrug that has to be activated for it to be effective, similar to like Vyvanse, right? If you don't take it by mouth, it's not activated, so it doesn't do anything, right? Codeine has to be activated for it to become morphine, right? Codeine itself, unless it's metabolized, doesn't do anything. That's a good question. I'm gonna look it up and get back to you. I don't know. I'm not sure. I don't want to speculate and I'm wrong and I get embarrassed and someone memes me on the internet. I don't want that.
No, that would make sense though, because it still does have action when you just take venlafaxine before it's metabolized.
Because there are some people though, the reason why I'm leaning towards it not being a prodrug, because anecdotally I've had patients do well on Effexor and not do well on Prestige for whatever reason. Right? Now, same as risperidone. I've had patients do well on risperidone and they get put in Invega and they do horrible. And then they get put in risperidone long-acting injectable and they do well, right? Because 20% of that is risperidone, 80% of it is non-hydroxy, which we'll talk about when we talk about schizophrenia. So there's a little bit of a difference that it could be significant. Yeah. And there's some people too that do very well on Lexapro, but you put them on citalopram and they do horrible, even though citalopram is the active metabolite. You get it? It's like it's very strange. Strange. I don't know. Good questions though. See, these are the questions I want. You guys need to really like be fascinated by psychiatry. This is how you're going to be great practitioners. It's funny. I had a student I was precepting, and she was like, "Oh, I went to Hunter," and she was like, "I asked one of my professors about you because I know you graduated a few years before me." And they're like, "Oh yeah, I remember Richard Cloud." You know what they said about me? They said, "Oh, that's that guy that asked too many questions." I was like, "You know what? It's okay. That's why I'm here, right?" When I go to conference, I always ask questions. I'm always eager to learn, right? Always asking questions. That's how you should be. They used to like throw me out. Like, class is over. Ask me next week, you know?
I have a quick question. For MDD, can you just do we have to start with like the SSRIs, or can we like do mirtazapine or like the other drugs first?
You can do whatever you want as long as you can back it up with data. So when you're writing a paper and we have case studies and they say, hey, this patient has this and you don't want to start an SSRI, then find me data that shows it, right? Is there a guideline? CanMat guidelines, Canada, the Florida guidelines, the Texas guidelines, the ones that we use a lot. Are there guidelines that show that mirtazapine would be used as a first line? If you can cite it and there's someone using it, then fine. Can't be like a case study though, right? It can't be like expert opinion. It has to be like a good scientific paper that you can cite. And if the patient has issues with insomnia, like I said, has issues with appetite, and you can cite that, and that's your rationale for it, and you can tell me why you're choosing that, and you can give me the mechanism of action is why you're choosing that. I'm not going to take up points.
But is it just like safer to just start with like the sertraline and then like add on?
Well, most guidelines will say serotonin reuptake inhibitors first for MDD, right? Most of them are because they tend to be, less risk, less side effects, I guess. You could argue that. But why? Why are you asking? Because you want to start Rembrandt first?
I just like I was reading about like how it's like a 5-HT2/3 antagonism, and like it's good if you have some sexual dysfunction from the SSRIs. So then would you like just switch them? Like would you add it or would you
Well, the
just
thing about long-term mirtazapine is that it blows you up, right? It's a very strong 5-HT3 and 5-HTC. The 5-HT3 antagonism, I'm sorry, 5-HTC antagonism and antihistamine, which it helps you sleep. Those two receptors affect your hormones of leptin and ghrelin, right? So leptin is what tells you you're full. So if that's affected, you're going to keep eating because you're not going to feel like you're full. And ghrelin is going to be activated, so you're always going to be hungry. So sure, you might help the patient's depression, but they're going to be like 200 pounds when they stay on mirtazapine. Unless they're one of the few patients that have very fast metabolisms and they can take it and they're actually okay and they don't gain weight. There are patients like that too. But usually we don't use that because it's not a good long-term solution because patients will put on a lot of weight with it. Trust me, there's no medication that's a free ride for. I always tell patients that, right? They're going to say, why'd you prescribe this medication if you knew there were side effects? I'm like, well, every medicine has side effects, right? You don't know how your body's going to react, and that's why I'm here to monitor you and kind of see it. I give you different options. I had a patient that was smoking a lot of marijuana because they had no appetite and they were depressed. So I said, I'll tell you what, mirtazapine might be a good option because if you want to get your appetite up and you have issues with sleep, they would help. They wanted marijuana to help them fall asleep and also to get them to eat. Maybe with that patient, which I did, mirtazapine was first line. I used it, and that's how I documented it. Patient was not open to taking Lexapro, was not open to Zoloft, was open to mirtazapine, and my target symptoms are this and this. All right, and that's how you should write your notes, right? Whenever I train people, I always make sure when you write a good note is besides the patient history, what the symptoms are, but I am prescribing this medication and what are my target symptoms? Is it anxiety? Is it appetite? Is it energy? They don't write a note and say patient has MDD symptoms, diagnosis MDD, we'll prescribe mirtazapine for depression. Then why not do surgery? Why not do what is it about mirtazapine that's making you choose that medication? Because then if I inherit your patient, right, if we're working in the same clinic, how do I know why you chose that medication? Right? You could even say chose sertraline because mom had depression and had a positive response with sertraline. Therefore, there's genetic loading there. I will use sertraline, right? Or Paxil, paroxetine. We don't use it a lot because there's a lot of side effects, but mom has done well on Paxil, has now gained weight on it. Family history has tried other medications. Patient doesn't want to try Lexapro because mother did well on Paxil. We'll start Paxil. Patient is aware of weight gain, sedation, increased sexual side effects on Paxil. But I'm documenting that. All right, make sure you write your rationale. Prescribing lithium as an augmentation for MDD with sertraline because patient has a chronic history of suicidal thoughts that is not getting better. Patient has no history of kidney issues, has no history of hyperparathyroidism, has no history of thyroid. We'll check these labs regularly. All right, if abnormal, we'll refer to primary care. See, I'm documenting it, so at least my rationale is good. All right. What I don't want to see is patient has a GFR of 35, right? Has one kidney. We'll start lithium because patient has, first episode of depression, right? That wouldn't make any sense. Or patient is a 25-year-old mother in a long-term relationship, just got married, has first episode of mania. We'll start Depakote, right? Would that be smart? No. So this is your last class before your exam. I'm willing to go an extra 15 minutes if you guys want to review stuff. It's up to you. This is not a formal review. We don't do formal reviews, but you can pick my brain for another 15 minutes because you guys are taking your exam on Wednesday, right?
Can you go over deregulation and desensitization again, please?
Sure. So downregulation is when the neuron is being stimulated too much and your postsynaptic neuron wants to protect itself from excitotoxicity. So it's going to downregulate. At the same time as downregulating, it's going to become less sensitized, right? Because it's being stimulated. It doesn't want to be too sensitive because it's already being stimulated. If you're blocking that postsynaptic receptor with a strong antagonist, over time, it's going to upregulate and become very sensitive. So you're going to have not as many receptors, but whatever's there is going to be extra sensitive. All right? Does that make sense?
Can you go over inverse agonist?
Inverse agonist?
Yeah.
Okay, so inverse agonist, when it binds to the receptor, it doesn't block it, it doesn't innervate it, it just shuts it down. So there's no intrinsic activity. There's not many inverse agonists in psychiatry. There's only a few. Clozapine is one, pimavanserin is one. We're going to talk about that in schizophrenia, but for this test, for mood disorders, we don't really use inverse agonists. But just know that it shuts down the receptor and there's no intrinsic activity. all right? If you give an antagonist, there's still intrinsic activity that's happening, a little bit of the cascade. If you put an agonist, there's going to be a full cascade, right? You put an antagonist, it's similar. That's why sometimes antagonists are called silent. The only time an antagonist is significant is if you block it. If so, let's say, for instance, someone is trying to use opioids, right? So an antagonist obviously is significant because the mu opioid receptors can't bind to it and can cause respiratory depression, right? But at the same time, it's not going to cause analgesia either, so patients will still be in pain. But at that point, the naltrexone or naloxone you're using is significant, right? Because it's blocking the binding of the opioid receptors, of the opioid, I'm sorry, to the receptors. But if someone's not using opioids and you give them naltrexone, it's not going to do anything, right? Because there's no stimulation there. Does that make sense? That's why it's silent. It's really only significant if there's innervation of it. Of course, it could be used as maintenance if you don't want someone to use. So we give them naltrexone just in case they do use the antagonist. So if someone gets an antagonist, is the affinity of the antagonist have to be stronger than the agonist? What do you think? Yes or no?
Yes.
Well, of course,
Yeah.
it has to be, right? Because if not, then the antagonist is going to get bounced off. So you have to create a molecule that the antagonist has to have a higher affinity than the molecule itself, or else it's not going to do anything. It's going to get bounced off once you use that molecule. It's going to bounce it off.
There was something in the spell book that was kind of confusing with the wording about desvenlafaxine and venlafaxine, the differences. The desvenlafaxine has relatively greater norepinephrine reuptake inhibition than venlafaxine, but it's still more potent at the CERT. Then it also said that desvenlafaxine has greater net inhibition relative to CERT inhibition compared to venlafaxine.
Yes, it does. That's why I was telling Evan that it wouldn't be considered a prodrug because they kind of have different mechanisms, right? So when you convert someone to Pristiq, desvenlafaxine, the ratio is actually 10-1, very similar to duloxetine. So if you give someone just Effexor, it's actually going to be 30-1.
Mhm.
Yeah. So it's a little bit different. Yeah. Some of it, not all of it gets converted. Yeah. So I know it gets a little confusing. Yeah. Hey, Enrique, are you there? I think he's from like another part of the world right now. Enrique, are you like in another country? I got your email.
No, that wasn't me. I think that's Alejandro.
Oh, sorry.
Yeah,
Oops.
no worries.
The questions for the test, what format does it take? Is it like scenario based or
A little bit of both. But this first test is actually going to be more definitions than the other tests are going to be because I have to establish that you have understanding of the basics. So I'm not going to give, too many scenarios at that point, but there's going to be some. All the questions are handmade by me with love, so don't worry. I don't recycle questions. I mean, I do recycle some, but if it's scenario, I usually change them up every year, every semester. For the students that are precept, if you guys see these pop things behind me, they usually give that to me as a gift. So if you guys want to get me a gift, you can get me a pop thing for my room. I'll display it for the next students that take it next semester. It's like back in the day when people used to keep the skulls of their opponents. It's like the skulls from the other students that passed my class. Come on, you don't have any other questions? You got 5 minutes. So next week, I have some bad news. Unfortunately, I have to do a program somewhere, so I'm not gonna be able to do a live class. What I'll probably do is I'll upload some stuff for you guys to read. So next week on the 28th, I'll put a posting on it on Brightspace. All right. So take that time to study. You can watch the videos again, and we'll start back the following week. It's another heavy topic. We're going to talk about anxiety and schizophrenia. So I'm probably going to spend 2 weeks in that on schizophrenia because it's a lot. If you guys want to get ahead, just watch the videos that we had before. It's pretty much going to be similar stuff. Would it be appropriate to put someone on 2 SSRIs at the same time? Anyone see that in practice or no? When would you see 2 SSRIs at the same time? When you're doing cross titration, right? Let's say, for instance, someone wants to get off Lexapro and they want to start sertraline, we usually do a cross titration. So you reduce one and you go up on the other, all right? So maybe for like a week or so, they might be on 2 meds at the same time, but don't keep them on 2 SSRIs at the same time, right? There's no data to show that's more effective, and you don't want people on not that you're worried about serotonin syndrome, but you should know about serotonin syndrome, all right? Know what the side effects of serotonin syndrome are. Clonus, hyperreflexia, right? Autonomic instability, your blood pressure and pulse are going to fluctuate. Confusion, right? Those are signs and symptoms of serotonergic toxicity or serotonin syndrome.
And you could use fluoxetine to bridge if you want to take somebody off of an SSRI.
You could, if you wanted to, if they were having a hard time getting off it, you could. Yeah. I've never had to do that too many times though, only a handful of times. Most of the time it's getting someone off an SNRI, which is difficult for them. Yeah. But people can have withdrawal on SSRIs also. Yeah, I've seen it. Flu-like symptoms. Which 3 SSRIs are potent inhibitors? That's good to know. You guys should know that. BFP, bupropion. I'm sorry. Bupropion is a DNRI, but just note for antidepressants, bupropion, Wellbutrin, fluoxetine, Prozac, and paroxetine, Paxil are potent inhibitors. So if any of those medications, make sure you make adjustments, right? So inhibiting means reduces CYP enzymes, but increases the drug concentration of whatever drug that's metabolized by an enzyme, all right? So if you put someone on Abilify or risperidone and they're on Wellbutrin or Prozac, make sure you adjust the dose or else they're going to have high risk of side effects from the risperidone or Abilify or any other meds that are affected by that. Or beta blockers, 2D6, right? Beta blocker like propranolol. That could be a problem because they can pass out, right? Too much blocking of the beta receptors can cause them to have orthostatic hypotension when they change positions and they can pass out. That happened to me with a patient actually. She was on risperidone, which has alpha blockade. She was on trazodone, that was alpha blockade, and the mom was like, she passed out. What happened? she ran track for school. She was in high school and she just wanted to get home, take a shower. She wasn't eating enough, she wasn't drinking enough, and she took a hot shower and she took her meds and she passed out in the shower. Combination of the risperidone, the trazodone, and the lack of fluids and the very hot shower that caused her vessels to dilate. All right. Thankfully, she was okay. She was just seen at the urgent care, but 5 minutes. Come on. Any other questions? So just know compounding side effects can worsen things. All right. Whatever the side effects of the meds are. Remember, increased serotonin can also affect clotting. So if someone's on like Coumadin or any meds that can affect clotting, make sure you counsel them on that also. All right. Sometimes some surgeons will actually tell them to stop their SSRI before the surgery, depending on how significant the blood loss could be.
What were the three pro inhibitors again?
BFP, bupropion, fluoxetine, paroxetine. Big freaking problems. All right. Bupropion, fluoxetine, paroxetine can cause big freaking problems if you don't know that. BFP. When do you know when to augment or when to switch medication? Jerry, when would you augment and when would you switch medication? Give me an example of when you would augment.
If they were having side effects that they couldn't deal with in some way, or not having enough of a response.
Would you augment or switch?
I think it would depend on which thing. If they were having particular
So
types
when
of
would you,
side,
so when would you augment? When would you augment, I guess?
I would augment if they were having lack of response to the medication that I put them on to start with, the monotherapy.
So you would augment if they were having no response? Why
If
not
they
just
were
switch? So if there was no response, why not just switch then? Because it's not doing
not
it.
not no response, but if they were having if they weren't having enough of a response.
Okay, okay, I understand.
Yeah,
Okay,
yeah. But if
okay,
there was no response, certainly I would try
okay.
a different
Leave it like
class or
that.
something.
Okay. Yeah, that makes sense. So if someone has a partial response, I usually tell patients I want to keep those gains, right? So therefore we add something, hopefully, and keep those gains and add something like Wellbutrin. If you're having, improved anxiety, less intrusive thoughts with the serotonin reuptake inhibitor, and now you're having sexual side effects or you're still having issues with focus and inertia, sure, I would add, a DNRI. I would refrain from adding an SSRI, an SNRI to an SSRI though, right? Don't add like Effexor to fluoxetine if you're going to augment. That doesn't really make any sense because you're giving them too much serotonergic. That's similar, especially at low doses. It's going to be similar to having them in two SSRIs. I would add Wellbutrin. Sometimes what happens when kids are depressed, they might have, instead of low mood, they might have agitation. Not bipolar. They're just very irritable and angry, right? Maybe at that point, you would add a low dose of Abilify, aripiprazole, right? Let's say if they're destroying the house and they're punching holes in the wall, they're not listening to the mom, and they're not manic, they're just, have irritable mood. Maybe a low dose of Abilify would be justified with that. And you would add that, right? Risk and benefits were discussed with the parent. Kid could be dangerous to self when having tantrums, has been aggressive at home. We'll add low dose Abilify. Mom is aware of the risk of metabolic symptoms and risk of tardive dyskinesia, right? We'll monitor AIMS every time I see them. abnormal involuntary movement scale, and I would check them for dystonia at every visit, right? Document that. And as they get older, sometimes the frontal lobe develops, right? You teach parents that. As someone, usually males take a little bit longer, right? Our frontal lobe can develop up to age 25, females a little bit earlier, early 20s. So once the frontal lobe gets better, then you can wean them off the Abilify, right? But don't keep someone on D2 blockers unless there's reason for it, like really, really bad aggression or history of very bad mania or psychosis, if you can manage it otherwise. Because then you want to make sure that the risks of staying on it don't outweigh the benefits of it, right? Initially, because what happened is people are afraid to stop the meds because they're not sure if the patient will get worse. It's worth a try to get them off the meds because you don't really want someone who's been on Abilify since age 9 for aggression to stay on it if they don't have like schizoaffective bipolar or, schizophrenia, right? Because their frontal lobe might be developing. You might be able to wean them off it and see. But you see that a lot. You see kids on long-term antipsychotics and, it's not good for the outcomes, especially since childhood obesity is already, an epidemic. It's pretty bad. All right. Okay, well, it's a lot of information. We covered a lot today. Watch the videos, all right? All my old videos is the same stuff on depression. Remember, the test is from week 1 to week 5. So it's covering a big span of pharmacokinetics, pharmacodynamics, which is a lot by itself, and mood disorders, which is unipolar depression, and bipolar disorder, which is, bipolar depression all the way to mania and maintenance phase. Know how to prescribe lithium, know how to monitor for lithium, know what the side effects are, know how diet affects lithium, know Depakote, how to adjust it too. We talked a little bit about albumin last time, how it's highly protein bound. So that can, I know, Misun, you asked about that. So if albumin starts dropping, you're going to have to adjust the Depakote or order a free Depakote level because there's going to be increased release of Depakote, right? That's going up the CNS. Okay, make sure you know that if you add lamotrigine to someone who's on Depakote, you have to give half the dose. All right, lamotrigine. Make sure you check the skin for Stevens-Johnson. One of my lectures, I talk about that for about 30 minutes, so make sure you watch that. I think one of my bipolar lectures. So make sure you check for rashes. You counsel them in Stevens-Johnson, right, which usually has myalgia, joint pain, fever, right, rashes that are on the mucosa, right, rashes that spread from the body to the peripheries. That could be Stevens-Johnson, all right, accompanied by fever. Make sure you stop the medication right away and you send them to the urgent care or ER, okay? All right. Good luck on the test, and I'll see you guys in 2 weeks. Feel free to email me if you have any other questions. All right. Have a nice weekend.
Thank you.
Thank you.
You.
Welcome. Bye.
Thank you.
Thank you.